So the case I'm going to present has been recorded in the Cardiovascular Center in Aalst, Belgium. The patient is a 72-year-old lady with diabetes, dyslipidemia, and obesity. She had recently an inferior STEMI in December 2020. The culprit lesion was located in the proximal right, as you can see from the left coronary angiogram. And on the right, you can see the final result after the implantation of a 323 stent. But this was a case of a multivessel disease. Indeed, here we see that there is a moderate stenosis in the mid-LAD and a mild to moderate stenosis in the distal circumflex and in the first marginal branch. So our plan was to perform a physiology guided PCI, so to evaluate the hemodynamic impact of this stenosis, and also to perform a post-PCI physiological assessment. Do you want to go on, Emanuele?
Thank you very much. And that's the way it starts, as usually. There is a calibration phase where we make the console, the Vivo Cardio console, speaking the same language of the MACLAB console. So once the aortic pressure is calibrated, we open up the fluid fill connector and we get synchronous measurement of the aortic pressure. As we usually do after a primary PCI, this patient was taken back to the cath lab a couple of days later. We checked the patency of the stent recently implanted in the culprit vessel. And as you can see, the vessel was fine. The flow was fine as well in the right coronary artery. Let me take also this opportunity to thank Katia Van Kutsem and Eddie, who were the nurses helping us during this recording. Now, this is the right coronary artery. You will see now the left coronary artery. The quality is a bit better as the one seen in the slides. And you can appreciate these intermediate stenosis in the mid-circumflex and in the first marginal branch. Now we move to a cranial view where you see this long lesion in the mid-LAD. It's actually a little bit longer if you pay attention than what we see on the angiogram. The disease starts even earlier than the first diagonal branch. Let's see in this angiogram. So the disease starts before the diagonal branch and goes way beyond the ostium of this side branch. In this specific moment, we took as a guiding catheter an EBU 6 French. We are transradial right in terms of vascular access. And this is again another projection that makes you better understanding the anatomy of this LAD lesion. So what we did in this case, we took the patient back, as we said before, and we started the functional evaluation of the circumflex. What is the advantage of the TruePhysio microcatheter? You use the guide wire you want. We used, in this case, a BMW wire that we position in the circ. We are now ready to take the microcatheter. What we do to start with, we unpack the device. We flush with saline, pure saline, the plastic hose that contains the microcatheter. And then we connect the microcatheter to the console, as you see done in this moment. There we go. On the display of the console, there will be popping up this 0 PD. All what we have to do is to push on that. And we are now ready to introduce the microcatheter within the guiding catheter. You know, it has a short monorail that you can appreciate now that I'm loading the microcatheter on the guide wire. Let's follow this step. You know, it's a very tiny microcatheter. As Luigi was alluding to before during the presentation, this is really a good profile. It's so thin that nearly mimics the tip of a guide wire. And that is why I suspect this microcatheter can really advance and slide everywhere without any kind of problems. Now you will see the guide wire coming out of the short monorail, just to give you an idea of the monorail segment length. And now we introduce the microcatheter within the guiding catheter, much like we would do with any kind of monorail balloon. You know, once we are with the tip of the microcatheter at the level of the tip of the guiding catheter, you can clearly see where the tip of the microcatheter is, because we have these two radiopaque markers and the pressure sensor is just in between these two microcatheter. It is the moment to flush the system. So what I like to do on my manifold is to take out the syringe with contrast, take a new syringe and flush the whole system in order to make sure that there is no residual of contrast within the guiding catheter that can dampen the pressure tracing. At this very moment, I perform the equalization by simply pushing on that button. The two pressure, the aortic pressure and the pressure measured by the microcatheter, are perfectly superimposed. At this moment, we are ready to advance the microcatheter. All what we have to do, because we already have in mind the localization of the stenosis, we have to advance the microcatheter and induce hyperemia. Now, in our case, we use intracoronary papaverine. And you know, papaverine and contrast do not really go well along. So if you have to inject papaverine, you have to make sure that contrast is flushed away. And that's what we did from the beginning. Now, we start recording and we inject the bolus of papaverine. You see, that's the advantage of combining microcatheter with papaverine, because we don't have to use again contrast when navigating the pressure wire within the coronary artery. The guide wire is there. All what we have to do is to push the microcatheter distal. This is the FFR. Yes, please.
Sorry, Emanuele, just a quick question. After papaverine, do you flush with saline or just you inject papaverine and you wait?
No, we flushed with saline. As you noticed, Simone, I injected 3 cc within the dead space of the guiding catheter. And when you saw me injecting with saline, it was just pushing forward the papaverine that was already in the dead space of the guiding catheter. So it's in a way, yes, to give you an answer. So there we go. This is the assessment of the circumflex, 0.92. At this moment, all what we have to do is to pull back the guide wire and go to the marginal branch. Now, we record the first measurement, 0.9, as we saw on the console of the microcatheter. Now, we move on. At this moment, I lead contrast, and I ask to Emanuele to inject some contrast because I'm navigating the wire, repositioning it. But that is the only moment I give contrast. Once the guide wire is in place, I already know where the pressure sensor should be located in order to assess that particular lesion. So again, the two markers at the tip of the guiding catheter, let's remember the sensor is located between the two markers. We check again the equalization. There we go. I already flushed with saline. In the interest of time, it's cut from this video. I advance the microcatheter. Okay, this is the resting PDPA. And there we go again. Papaverine in the dead space of the catheter. I ask to the nurse to push on rec. There we go. Now we are recording. I wait a few seconds to have resting PDPA recorded, 0.98, 97. Open the stopcock, inject saline, pushing forward the papaverine that is already in the dead space of the guiding catheter. And now we observe now the hyperemic response. Please notice also the time of each measurement. Less than 1 minute, actually, the first one. The second one, we pull back, we check the equalization, we check actually if the two pressures are going back to 1, and then we stop recording. So this was also not significant. Now, what you see here, 0.73, that's actually an error that the system does in detecting the maximum pressure gradient between the aortic pressure and the microcatheter pressure that we can correct afterward in data archiving, but I'll share this with you at the end of the session. Now, the second lesion is also non-significant. We reorient the guide wire towards the LAD. We change projection, as we all do in our daily practice, and we advance the guide wire to the LAD. Very safely, always with the same B&W wire. Cranial view, again, the microcatheter at the tip of the guiding catheter. We reconnect papaverine at the stopcock. We take another syringe with saline that we connect at the other stopcock of the manifold. That's what I'm asking to Emanuele. There we go. We make sure that the contrast that is in the guiding catheter is completely flushed away. So a couple of, you can also see that the composition of the syringe with papaverine is different, the density from the composition and the density of the saline. Now the system is ready. We check the equalization again. Eddie, our nurse, pushes on equalize, but you see it's always one. We just do it in the interest of education. So PDPA is 1, equalization is correct. Then we advance the microcatheter into the distal LAD. I know exactly where the stenosis is, as I use the radiopaque part of the guide wire as the landing zone, if I may say so. Now we are distal. At this point, I ask to record the pressure tracings. You will see that shortly the record button will turn to rec. There we go. And now we inject papaverine in the dead space. Actually, it's at this very moment that I push on record. There we go, in order to have a clean measurement from the beginning till the end. Now we are recording. That's the resting PDPA 0.86, 0.87, 88, okay. And you saw now that the aortic pressure is just interrupted shortly because I injected papaverine, and now we see the hyperemic response. It's going down, 0.84, 83, 81, 79, and I guess the lowest value will be around 77, 78. But you see there is a significant hyperemic gradient. There we go. We stop recording, and what you see, it's a snapshot. Yeah, the lowest value is 76. You will see a snapshot that the system recognizes as maximum pressure gradient. Of course, I do the pullback also to see where most of the hyperemic gradient is located. We stop recording, equalization is more or less okay. Voila, it gives you 0.63. Again, it's the usual trick that I mentioned before, that the system captured the maximum pressure gradient. That doesn't mean that is the correct FFR, but in the data archiving phase, we will demonstrate how to pick the correct pressure gradient also for future recordings.
Okay, so basically then for the PCI, we place 2 wires, 2 BMW, one in the LAD, and the second one in the first diagonal branch. Then we used a semi-compliant balloon, a 2.515 for the predilation of the lesion. The balloon was inflated up to 10 atmospheres in order to achieve a good lesion preparation. And then the stent was advanced quite easily through the lesion. The stent is a 2.75, 33 millimeters. We placed it carefully in order not to leave any residual plaque at the proximal or at the distal edge of the stent. So we placed it carefully under fluoroscopy. And then the stent was deployed and the balloon was inflated up to 14 atmospheres. Then we retrieved the balloon of the stent and we performed a POT, a proximal optimization of the stent expansion with a non-compliant balloon at 312. Also, in order to facilitate afterwards the wire exchange. So this non-compliant balloon was inflated up to 14 atmospheres. Then this is the the result, then we perform the wire exchange. So basically the wire from the LAD was retrieved, the tip was kept in the stent, and we crossed the stent struts in order to place this wire in the diagonal, and here we go. And then now we have the wire that was previously placed in the first diagonal that of course is jailed. So then we pull back the jailed wire from the first diagonal carefully, because we always have this movement that the guiding catheter tends to go deep in the coronary artery, and then we place this wire in the distal LAD. So after the wire exchange, we perform the kissing with the semi-compliant balloon 315 placed in the LAD and the 215 placed in the first diagonal branch in order to better open the struts of the stent towards the first diagonal branch. And then, of course, we finish with the final pot with the non-compliant balloon 312. Also, in this case, we used the stent beads in order to place properly the balloon. And you can see from the stent beads how the struts of the stent towards the first diagonal branch are well open. Then we inflated the balloon up to 18 atmosphere for the final pot. So basically we perform the pot, kiss, pot strategy. And here you can also see again the final result with the stent beads. And here we see clearly the struts of the stent in the diagonal branch.
We did post-PCI evaluation. Again, microcatheter at the tip of the guiding catheter. We check the equalization. It's 1 at this moment. Always consistently, same protocol. We advance the microcatheter up to the landing zone we've given us in the beginning of the physiologic assessment. We close the stopcock, we close the valve of the guiding catheter. We see again the two pressures are up. This is now the resting PDPA. There we go. We flush the system with saline. We start recording. Few seconds to record the resting PDPA. At a certain point, you will notice that the aortic pressure interrupts. We inject adenosine, there we go. And we get the hyperemic response in the vessel. So this is the first information. FFR post is 0.93, so way above ischemic threshold of 0.8. And at this moment, we do the pullback that gives you a second information, how much I can improve this post-PCI FFR. Is there any residual focal gradient that I can treat with an additional stent? And what this pullback tells us, we stop the recording in a short while, what this pullback tells us is that there is diffuse residual disease. So there is no way I can improve this residual grading by additional stenting. And last information, the measurement was correct because the final PDPA was 1. Now you see we are going without any problem to a diagonal branch, and it took us no time to get into the diagonal branch without any effort. And at this moment, again, we flush the system, we induce hyperemia, we ask our nurse to push on REC. There we go. We are ready. We inject the hyperemic stimulus inside, and we wait for the hyperemic response. So towards the diagonal branch, the FFR was 0.90. Again, we do the pullback, and we see again this diffuse gradient all the way through with a good equalization at the end. We stop recording, and what you saw again, it's this artifactual number that I'll explain you in a while how to correct it. Final angiographic acquisition here. I would say good angiographic result, good functional result, 0.93 in the LAD, 0.9 something in the diagonal branch. We are finished. Now it comes a very important moment, data archiving. This was one of these artifactual measurements. Why? Because the system takes the measurement where the simple volume is located. So all what you have to do is to place the simple volume at the stable hyperemic response, push on the FFR, recalculate, relocate the FFR, and that gives you the right value. In addition, if you want to revisit the measurement later on, days after, you need to recall what you did. So tell the system whether you measure the LAD, the circumflex, the marginal branch. So there is some legends in the system. Tell the system whether it was pre-PCI, post-PCI, whether you used adenosine, papaverine, because this information will be useful later on. And at the end, you can review all your measurements, 4, 5, 6 measurements. You see how many we did. And each of them did not last more than 1 minute. So we did a multivessel disease functional assessment. I think we can stop sharing the screen. We did a multivessel disease functional assessment without any further waste of time. In total, 1 minute each. So in 5, 6 minutes, you have pre and post PCI assessment and evaluation.